Thank you, Dr. Neeraj Gusani, for talking to us today about liver surgery. First of all, tell us a little bit about yourself.
Oh, thanks, Chris. It's a great pleasure to be here. I've met you in person, but this is the first time we're meeting virtually, so it's kind of fun. But I'm a surgical oncologist by training, a general surgeon. I did a surgical oncology fellowship, and I'm in practice at Penn State Hershey Medical Center and Penn State Cancer Institute in Hershey, Pennsylvania. I did my surgical training. I did my medical school at Penn in Philadelphia, surgical training at the University of Chicago, and then a surgical oncology fellowship at Pittsburgh, where I focus mostly on GI and abdominal tumor surgery.
Great. So liver surgery back in the day seemed like something very high mortality, very scary for surgeons, and it seems to have come quite a ways in the past 10, 20 years. Can you tell us a little bit about that evolution of liver surgery in general, particularly with attention to energy devices and techniques?
Yeah, Chris, it's really a vast change even since I don't think of myself as that old, but even since I was a junior resident, things have changed quite a bit, and liver surgery is indeed still a big endeavor and still a big physiologic insult for the patients, but it's much, much safer now, and it's a combination of things. Technology is wonderful. That's why we're meeting today, or how we're meeting today. But it has helped us tremendously in all aspects of surgery. We have a much better understanding of the anatomy of the liver, and we're able to see that anatomy in real time in the operating room with ultrasound, and know exactly sort of a plan for how we can do our resections and how we can remove the least liver possible in the safest way possible. In addition, we have better preoperative planning in terms of the CT scans and MRIs, which can give us a 3D reconstruction of the target anatomy, and again help us figure out if the patient has enough liver to do a resection. And then in the operating room, we have great toys. All surgeons like our technology, and we use different devices. And there are a million different types of energy devices and cautery devices and sealing devices that can help us do a safer liver resection and a less invasive liver resection. We do a lot more minimum invasive liver surgery now, and so the patients recover faster and so on. In particular, certain devices have made hemostasis of the liver a much easier thing to achieve, and we can dissect around the major vessels and then control those major vessels surgically, again providing for a safer resection. And then the last thing, sorry Chris, is just our colleagues help us a lot in every aspect of surgery, and the anesthesiologists have gotten better. We use low CVP anesthesia so that there's less bleeding from the hepatic veins, which can be an Achilles heel from liver surgery, and our ICU colleagues are able to get us out of trouble and help our patients who are sick afterwards, if they do become sick, and help them to recover from complications much better than before.
Okay, low CVP surgery. I haven't heard of that. How do they manage that? What is the process?
So the biggest principle is that the hepatic veins, which cause significant bleeding, are directly connected to the IVC, the inferior vena cava, and so the pressure, the central venous pressure, is directly reflected in the liver. So we ask the anesthesiologist to give as minimal fluid as possible. It's kind of similar to doing a thoracic surgery. We keep the patients as dry as possible, essentially shut down the fluids after induction, and then give very little until after the surgical resection is completed, at which time we can then tank the patient back up. So we tolerate a low CVP, even sometimes allowing pressors, which we normally hate, if we need to maintain the patient with a certain blood pressure without giving fluid. There are other ways people have tried to do this. People have actually done phlebotomy, and there are some randomized trials that show a effect of preoperative phlebotomy, where we take blood off at the beginning of the case, give it back at the end of the case. So that's another option as well.
Interesting. And what are the hemostasis devices that are in use commonly in liver surgery now?
Well, everybody has their favorite, and I don't shill for any company, but people use the old-fashioned argon plasma coagulator. There are ultrasound devices like the CUSA There are other water jet devices. One is called the Irby. There are sealing machines like the ligature and the harmonic, which we can use actually on the parenchyma. We use other devices like the aquamantis and the tissue link to try to get hemostasis of the parenchyma, and then finally we use staplers, often to control the major vessels and the major biliary radicals within the liver.
Okay. And the majority of liver surgery for neoplasia, anyway, is colorectal metastasis, right?
Yeah, that's got to be by far the number one type of malignant neoplasm in the liver in the United States. Worldwide, it's of course HCC, which we'll probably talk about a little bit later. Internationally and in other countries, viral hepatitis is so much more common that a lot more people get HCC. In the United States, hepatocellular carcinoma is thankfully quite rare, but colorectal cancer is the third most common cancer in both men and women. Estimates are that there are about 150,000 cases per year in the United States, and a good number, about 40%, will get metastasis, and by far the most common site of metastasis is the liver. And the interesting thing about this, as you know, is that colorectal cancer is one of the few cancers that even at stage 4 can be treated for cure. And so liver resection for colorectal cancer has a tremendous potential to provide survival benefit as well as possibly cure to the patient.
Yeah. And what modalities are now in use that may not be familiar from 10, 20 years ago for managing colorectal mets? I'm thinking of things like TACE and RFA and neoadjuvant treatment.
Well, I think the most important is this idea of the multidisciplinary team. In every cancer center and in many hospitals, we have multidisciplinary clinics where the colorectal surgeon, the liver surgeon, the medical oncologist, the radiation doctor can all see the patient together and make a plan together. And we often do combination therapy, so patients get chemotherapy first, as you said, neoadjuvant chemotherapy sometimes, followed by resection. They can get resection followed by chemotherapy. We can sort of do sandwich protocols, and the idea is that with the combination of chemotherapy plus surgery, we make a lot more patients resectable and take less liver, and we can pick out the patients who have the best chance of survival after a liver resection.
Mm-hmm. And how about RFA and TACE? When do you employ those?
Yeah, I think the default is surgical resection, Chris. We try to resect liver metastasis as often as possible because we think it gives the best chance for cure. But radiofrequency ablation, RFA, can be used, and now more modern technology that's coming into play is microwave ablation. These can be used to treat tumors that couldn't necessarily be resected or might be difficult to resect, or can be used in combination with resection. So we resect some tumors, ablate others to get a complete clearance of all the tumors within the liver, and that can be a potentially curative technique as well. Wow. Hepatic artery-based techniques, so you put a catheter in the groin, snake a wire, and put a catheter into the hepatic artery branches, and you can give selective chemotherapy, so that's TACE, transarterial chemoembolization, or you can give radioembolization, so you give particles that have yttrium microparticles, and they are low frequency radiation emitters. And so these give directed radiation to the liver. And we use TACE commonly in HCCs, and we use radioembolization sometimes in unresectable colorectal metastasis.
Now I'm just curious, when that is, when you're instilling those things, do the people keep a catheter and get a few treatments over the course of a period of time, or is it a single installation of the drugs?
It's usually single installation. You'll go to the interventional radiology suite. They'll access the vessels. They'll inject the drugs, and then they'll take the catheter out. And these procedures can be repeated, so you can have multiple episodes of TACE or radioembolization as needed. These aren't curative modalities. They're palliative. but they can get good shrinkage of the tumor and often keep people alive for longer than they otherwise would have. Okay. In combination, again, with chemotherapy, it has to be acknowledged that chemotherapy provides an amazing benefit for colorectal cancer metastasis. In fact, without the medical oncologists, we wouldn't be able to do some of the things we can do in terms of liver surgery.
Yeah. Okay. How about in hepatocellular cancer? What's new in management of or how are these usually discovered and how are they managed these days?
Yeah, unfortunately, it's still often a very late diagnosis. HCC, hepatocellular cancer, as you know, and most of our audience knows, arises usually in a background of inflamed, chronically inflamed liver. So patients with liver cirrhosis from any cause are at risk for hepatocellular cancer in the whole liver. So you can have one or sometimes, unfortunately, multiple HCCs that develop in this inflamed liver. The most common causes are viral hepatitis, so hepatitis B and C, as well as alcoholic cirrhosis. But we're seeing sort of an epidemic with our obesity epidemic in the United States. We're seeing an increasing proportion of fatty liver disease.
Sure.
And fatty liver disease, or NASH, non-alcoholic steatohepatitis, can progress to cirrhosis as well. And sometimes you have a combination of things. So a person has viral hepatitis as well as fatty liver, and it can become a big management problem. So anyway, these patients have cirrhosis. Cirrhosis then leads to a hepatocellular cancer. Some people are in a screening program, so if they have known viral hepatitis, they'll be screened periodically. But often these are found very late when the patients have fatigue, they have weight loss. Sometimes they'll present with jaundice, and that can be a sign that the major bile ducts are blocked within the liver, and they'll present. But very often the presentation is late, and the patients are incurable at that stage.
Right. Okay. Well, that's good. I think we'll break off some other topics for another day. Last words on hepatocellular or liver resection?
Well, I think it's going back to this combination treatment modalities have really changed everything for us. Certainly we have better surgical techniques, but in colorectal cancer, the average survival for somebody getting chemotherapy has more than gone up from 6 months to 12 months to now almost 24 months just in the last 10 or 12, 15 years. And so amazing progress in chemotherapy. In HCC, it's more progress in terms of chemoembolization and other adjuvant therapies, but the combination of these other therapies given by the medical oncologists or the radiation doctors or the interventional radiologists, along with surgical resection, brings more and more people to potential cure. And we do liver surgery safer, as I mentioned, and so we get people through that way. It's a fun time to be a liver surgeon. There's a lot more things we can do, and it's a growing field.
Great. Well, thanks for talking to us today. Good to see you.
Thank you, Chris.
Take care. Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook, follow us on Twitter, and find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.